So as Randy mentioned, I live in Hood River, Oregon, and I'm the residency director here. I've been practicing family medicine since I finished residency in 1987, and I actually moved here to Hood River to work at a community health center, migrant community health center in 1988, and had done an obstetrical fellowship a year before that. So I came up here thinking I knew everything, and then I quickly realized that I was pretty dumb. But I learned by experience from my patients, and over the last 30 years, I've also been lucky enough to be involved in residency education, both in California and up here in Oregon. And so this has been a topic that is near and dear to me, and I'll just get started by doing a little overview. So the first question is, what's the big deal about gestational diabetes? And there was a time earlier in my practice in the 90s when there was a fair amount of debate about whether gestational diabetes was actually a disease. And there was a fair amount of controversy and actually a lot of lack of really decent data that supported the idea that maybe gestational diabetes was more than just something than a abnormal blood sugar. So basically, you guys already answered this question right. It does affect about 6 to 9% of pregnant women. In my practice, which has a large Hispanic population, the number is 10%. So it does vary based on the nationality and the ethnicity in your practice. And then about 90% of the patients with diabetes in pregnancy have gestational diabetes. And as I mentioned, obesity and age also can affect the incidence. And we talked about the complications during pregnancy, particularly for the mother. That one question that Randy had up was a little trick question because he was seeing if you paid attention. And it is true that hypertension and preeclampsia are complications of the pregnancy for the mother. Obviously, the fetal complications are different. And that if it's undiagnosed, particularly if women are not screened and diagnosed with diabetes, it can increase the risk of perinatal mortality and obviously stillbirth. The other issue, I think, for a lot of us that are family physicians is that the risk of developing diabetes and related conditions later in life is significantly increased. And it is thought to be as high as 70% of women with GDM will develop it within 22 to 28 years. And so, and of course, the fetal and other maternal issues are increased primarily due to the macrosomia by causing more operative delivery, shoulder dystocia, birth trauma, and then, of course, low blood sugars. So we're going to go into a little case presentation now, and I'm going to tell you about a patient of mine. This is a real patient that I've had several years ago in my practice. So Maria is a 32-year-old woman who is a gravida 3 para 2, whose due date and gestational age by her LMP says that right now her gestational age is 14 weeks. That should be whose gestational age is 14 weeks gestation. So imagine this is your patient that comes in, she's 14 weeks, and you find out as you look at her chart that she has kind of some significant past medical history and obstetrical history. So she's had 2 previous deliveries in the last 4 years, and her last one was associated with gestational diabetes. And she was actually on glyburide for the last trimester of that pregnancy, for which she had a 9-pound, 10-ounce infant that had that needed a vacuum-assisted delivery and had a pretty significant shoulder dystocia. She otherwise had a normal postpartum course, but she never came back for her postpartum exam nor her screening glucola, and was on oral contraceptives for about a year. She comes into you thinking that she's pregnant, of course, and then you quickly have your medical assistant check her blood sugar and notice that it's 301 from her, I'm sorry, she tells you that her home glucometer says her blood sugar is 301 after her evening meal last night. So in the office, we got some important information after performing her initial history and physical, and her uterine size was about 8 weeks along, and I couldn't hear any fetal heart tones by a Doppler. We were able to get an ultrasound right away in the office since we do have that available to us, and The fetal crown rump length was 10.2 millimeters. That was consistent with a 7-week gestation, and there was fetal heart activity. We also did a point of care testing lab that revealed her random blood sugar was 275, and we do in-office hemoglobin A1Cs as well, and it was 8.5. And that's an example of her ultrasound. There's the little crown rump length there of the embryo. This is the yolk sac, and here's the gestational sac with the bright echochorionic rind around it. So it's a normal intrauterine pregnancy that we can tell. And she's clearly not as far as long as she thought she was by her last menstrual period. So we initiated her treatment with insulin, and we actually started her on NPH right away, given that her blood sugars were so high. We didn't admit her to the hospital. We did this as an outpatient, and just had her on 10 units of NPH twice a day and had her come in in 3 days. We did a phone consult with our maternal fetal medicine specialist in Portland, Oregon. That's about 90 minutes away. And he agreed with our plan and suggested we see her every 3 days until she was euglycemic. And I did have some questions about her, though. I thought, gee, I was really relieved that she was only 7 weeks along instead of 14, because I was really concerned about the risk of miscarriage for her and also fetal anomalies, given her poor glucose control that was apparent probably pre-pregnancy as well as in the early first trimester. And then I kind of wondered, here she was, we took care of her in her last pregnancy. It was an eventful delivery, and we lost her to follow-up. She didn't come back in for her postpartum exam, and that troubled me. And then, and so why didn't she come in? So the first thing that I was concerned about was whether there was a risk of congenital malformations because of her poor glycemic control. And it is true that about 6 to 10% of all diabetic pregnancies do have congenital malformations, and that's at least double the background risk for patients overall that are pregnant. And that there can be as high as a 40% perinatal mortality rate, oftentimes because of these cardiovascular and often nervous system abnormalities, which are most common. And there's been really good evidence that the congenital malformations are related to hyperglycemia during the period of organogenesis, in the sense that hyperglycemia acts like a teratogen, and that strict control reduces the structural defects back to the background level of 2 to 3%. So really having that patient in optimal glycemic control before they get pregnant is the best possible care that we could have tried to offer Maria in this particular situation. And just briefly, the cardiovascular and nervous system abnormalities most common seen for the heart is you'll see endocardial cushion defects, and for the nervous system, it's primarily meningomyelocele. So early screening for these is important. But as we went on and talked about this, we thought about her a little bit more from the framework of considering social determinants of health. I'd like to tell you a little bit more about Maria's story. So Maria is undocumented, and she is also employed in farm work. And shortly after her delivery last year, which was in that year was in June, her husband traveled north to follow the cherry harvest. And here in Oregon, many of our patients travel up towards the Yakima Valley and then even up into British Columbia to follow the cherries. And they usually do that through the summer until they're back in the fall when they start harvesting the apples and pears here in the Hood River Valley. And then when she returned back to Oregon at that time, her infant was already 4 months old. She didn't come back for postpartum care, and she went to the health department to get birth control pills and didn't come back to our health center. And she moved to a different orchard where she lived. So her numbers and addresses were different, and our staff couldn't reach her for follow-up. They tried anyway. So it was, and the other thing about her that was interesting is that she admitted that the main reason that she didn't come back earlier is that she did not want to find out that she had diabetes. So she was trying to avoid the diagnosis by avoiding to get evaluated. And the main reason is because she was very afraid to be put on insulin. So a little bit more about our story with her. So we're very fortunate in our health center is that we employ community health workers. Our Our community health workers, Maria and Delphina, who you see here, are actually women that are bilingual, bicultural, and used to actually work in the farm working community as well. And then they were trained and became community health workers by going through a program. And they really serve as essentially peer healthcare workers that assist our providers with the patients and provide a bridge so that our patients can have a sense of familiarity and comfort with people that are like them, that speak their language, but also understand the work that they are in and in their lifestyle. And with Vicki and Delphina's help, we were able to spend the needed time to help Maria understand how to administer her insulin, check her blood sugars, and of course, do the lifestyle modifications, eat healthier, have less sodas and juices and flour tortillas, and of course, exercise. And they also help coordinate all the referrals to have her see the MFMs in Portland a couple times during her pregnancy for some consults and high resolution ultrasounds as well. So the outcome of her story, I won't get into it too much, but she ended up getting put on insulin. She did not take that long to get into decent control. And we adjusted her twice a week until really about 16, 18 weeks of her gestation. And then she was pretty stable until her third trimester. Then we needed to up her doses again, which is commonly seen when patients are on insulin, is that the anti-insulin effects of the hormones of pregnancy, estrogen and progestin, need to be combated oftentimes with a little more insulin. But she ended up getting induced at 38 weeks due to the recommendations from our MFMs, and she delivered a healthy 7-pound male infant. And she decided on having a tubal ligation instead of getting a birth control through hormonal manipulation, and had a postpartum tubal. And then she did get a screening 75 gram glucose at 6 weeks. That was completely normal, which was kind of surprising to us. But she had really worked hard to not gain weight during the pregnancy. And so she was actually she weighed less actually after her delivery than before she became pregnant. And that had a lot to do with it. She's still afraid of developing diabetes, but now has more understanding and tools to keep herself healthy. And she knows that she's supposed to get checked every 3 years. Really, a lot of working with Maria is ongoing lifelong skills and lessons that she is really involved with. One of our community health centers has a program that's called Salud, which basically continues to take our pre-diabetic, diabetic, and hypertensive patients with lifestyle interventions. Here's one of the classes that are called PASOS classes, where they're learning how to grow their own food. She was attending Zumba classes, breastfeeding, and really kind of changed a lot of her own family's health habits and diet as well. So my summary of her, before we get into the learning activity, is really lessons for rural practice that I've learned over the years is, number one, use the phone. Luckily, we exist in a practice environment here in Oregon that is very easy to get a hold of our consultants. They're just a phone call away, and they're really, really positive about helping the rural family physicians manage their patients so that the patients can get the care they need in their community. It's helpful to have an expanded skill set to care for patients. This includes really being aware of what medications need to be used for patients with gestational diabetes, and having some advanced skills like ultrasounds. These things help reduce errors, improve the patient satisfaction, and also keeping up to date by local regional conferences. And I really think that ACOG and the AFP have done a really good job at providing conferences and also technical updates and bulletins that are much more evidence-based now. Again, relationships are key, so it's helpful to know your consultants and for them to know you. We've just been having a program with our own MFMs who come out every month and give a presentation, but they also are available so they know the clinicians in our community, and then have a team. It's all about that nowadays. It's not just all on our shoulders as the primary care physicians, but particularly community health workers, clinic RNs, and assistants really can help with our patients improve their compliance with care. And then lastly, again, walk a little bit in your patient's shoes, think and consider barriers, social determinants of health to try to improve access and compliance with care. And that's all I got. So Randy, I'll turn it back over to you.